Uveitis in spondyloarthropathies. These are a group of disorders featuring HLA-B27 positivity and enthesitis as a common factors. So there are two features, HLA-B27 positivity and enthesitis. Enthesitis is inflammation of the entheses. Entheses are the sites where tendons, ligaments and joint capsules attach to the bones. So there is often a family history of one or more of the group, which comprises ankylosing spondylitis, undifferentiated spondyloarthropathy, psoriatic arthritis, reactive arthritis, also known as Ritter syndrome, and spondyloarthropathy with inflammatory bowel disease, which consists of ulcerative colitis and Crohn's disease. Again, these are spondyloarthropathies. These are the two features, family history. So they are often referred to as seronegative spondyloarthropathies. In that, rheumatoid factor is not present and the pathophysiological basis different. So that's why they are seronegative. The American Uveitis Society has recently endorsed the use of biological blockers such as infliximab for second-line systemic immunosuppression in vision-threatening chronic uveitis. So the first one is ankylosing spondylitis, characterized by inflammation, calcification, and finally ossification of ligaments and capsules of the joints with resultant bony ankylosis of the axial skeleton. So it involves the axial skeleton as shown in the pictures. It more commonly affects males, of whom 90% are HLA-B27 positive. Systemic features: the presentation is commonly in the 3rd to 4th decades with the insidious onset of pain and stiffness in the lower back or buttocks. Spondyloarthritis causes progressive limitation of spinal movements and eventually the spine may become fixed in flexion. Here you can see in the picture spinal stenosis and fractures may occur. Next is enthesitis. Is characterized clinically by inflammation and pain at ligamentous attachment to the bones. Cardiology complications are rare. Radiology of the sacroiliac joints shows juxta-articular osteoporosis in the early stages, followed by sclerosis and bony obliteration of the joint as shown in the picture. Calcification of the spinal ligaments give rise to a bamboo spine. Radiological changes often predate clinical symptoms. What are the ocular features? Anterior acute anterior uveitis is by far the most common ocular association and occurs in about 25% of patients with ankylosing spondylitis. Approximately 25% of the males with AAU will have AS. Either eye is frequently affected at different times, but bilateral simultaneous involvement is rare. There is often no correlation between the severity and activity of the eye and joint involvement. Chronicity occurs in a few patients. HLA-B27 positive AS patients tend to have worse disease across a range of parameters, including earlier onset and greater intensity of inflammation with an increased frequency of complications. Other ocular features include scleritis, episcleritis, keratitis, and mechanical ptosis. Next disease Next spondyloarthropathy is reactive arthritis, also known as Ritter syndrome, characterized by a triad of non-specific urethritis, conjunctivitis, and arthritis. Around 75% of patients are positive for HLA-B27. A range of infective agents can trigger the syndrome, which develops in 1 to 3% of men after non-specific urethritis and around 4% of individuals after enteric infection, caused by a range of organisms including Shigella, Salmonella, and Campylobacter. Chlamydia, pneumonia, respiratory infection, and other may also precede the reactive arthritis or the Ritter syndrome. What are the systemic features of reactive arthritis? So there is a tip: patients with uveitis secondary to various spondyloarthropathies are often HLA-B27 positive. So presentation of Ritter syndrome is often with acute onset of malaise with fever and dysuria 1 to 4 weeks after a linked infection in a patient aged between 20 and 40 with arthritis that may be preceded by conjunctivitis. A variety of other features may be present, though not always the defining triad. Peripheral oligoarthritis is acute, asymmetrical, and migratory. 2 to 4 joints tend to be involved, most commonly the knees, ankles, and toes. Spondyloarthritis affects about 50% of patients, manifesting with low back pain. This sometimes becomes chronic. Enthesitis manifests with plantar fasciitis, Achilles tenosynovitis, bursitis, calcaneal periostitis. Reactive bone formation in the latter may result in calcaneal spur. Mucocutaneous lesions include painless mouth ulcer, cessinate melanitis, keratoderma brenorgica, which are the skin lesions resembling psoriasis involving the palms and soles, as shown in this picture. Genitourinary involvement includes cervicitis, prostatitis, and epidermitis. Aortitis occurs in 1 to 2% of cases. Ocular features: the eye is involved in 50% of cases with a urogenital inciting infection and 75% of enteric Ritter syndrome. Conjunctivitis is very common and classically follows urethritis but precedes arthritis. Inflammation is usually mild, bilateral, and mucopurulent with a papillary and or follicular reaction. Spontaneous resolution occurs within 7 to 10 days and treatment is not required. Some patients develop peripheral corneal infiltrate. Acute anterior uveitis occurs in 20%. Episcleritis sometimes occurs. Next is psoriatic arthritis. Up to 40% of patients with psoriasis develops arthritis. The arthritis is more common in whites than other racial groups and affects both sexes equally. There is a first-degree family history in 40% and more, and many genetic markers have been identified. The systemic features: presentation of psoriatic arthritis is usually in the middle age later than skin features. On the skin, there are multiple types of psoriasis. Plaque type: the most common form is characterized by well-demarcated, raised, silvery inflamed plaques on the scalp, trunk, arms, legs. Psoriatic erythroderma features widespread exfoliative skin changes with associated inflammation and pustular psoriasis, inflamed but not infectious pustules, limited or generalized in distribution. Nail changes: dystrophy occurs including pitting, transverse depression, and nycolysis. Arthritis is typically asymmetrical and involves the distal interphalangeal joints and sausage digits. Some patients develop enthesitis. So these are the nail changes. The acute anterior uveitis occurs in approximately 7%. Conjunctivitis, marginal corneal infiltrates, secondary Sjogren's syndrome may occur. Next disease is uveitis in juvenile idiopathic arthritis. Juvenile idiopathic arthritis is by far the most common systemic disease associated with childhood anterior uveitis with a prevalence of about 1 in 1000. It is defined as arthritis of unknown etiology that begins before the age of 16 years, and persists for at least 6 weeks. Up to 50% of children affected have persistently active disease after 10 years. It may result from exposure to one or more unknown antigen in genetically predisposed individuals. So the clinical features: arthritis. JIA is classified by the International League of Associations for Rheumatology according to the extent of joint involvement during the first 6 months. So it may be oligoarticular. It is the most common form. 4 or fewer joints are involved. The knees are most commonly involved, followed by ankles and then the wrists. The girls are affected 5 times as often as boys, with a peak age of onset around 2 years. Some patients subsequently develop polyarthritis. About 75% of children are ANA positive. So a strong risk factor for uveitis is ANA, which is common in affecting 20% of children, and in this group. Next type is polyarticular rheumatoid factor negative, also known as rheumatoid factor negative. Affects 5 or more joints, typically both small and large joints symmetrically. The female to male ratio is 3:1. The disease may commence at any age through childhood. Systemic features such as fever, rash may occur but are milder than systemic onset form. About 40% of children are ANA positive. Uveitis occur in 5 to 10% of cases. Systemic, also known as still disease. Systemic features such as fever, episodic erythematous, mucopupillar rash, lymphadenopathy, hepatosplenomegaly may precede arthritis. The disease occurs with equal frequency in boys, girls, and may occur at any age throughout childhood. The majority are negative for ANA, and uveitis is rare. So in this case, uveitis is rare, and polyarticular, very low risk of uveitis, and oligoarticular, it is the most common form. So oligoarticular, about 75% of children are ANA positive, which is a strong factor for uveitis. So after systemic still disease, there is enthesitis related psoriatic. Enthesitis means the inflammation of the connective tissue where tendon ligaments attach to bone. Psoriatic and undifferentiated are 3 other forms under the classification. The first two have a relatively high risk of uveitis, but the risk in the latter is low. In the undifferentiated form, there is low risk. Presentation. So anterior uveitis is a key cause of morbidity in juvenile idiopathic arthritis. It is particularly common in oligoarticular JIA and relatively frequent in several other types. Progression to blindness has been high in the past but shows a declining trend in recent years associated with improved screening and management. Arthritis usually antedates the diagnosis of uveitis. Presentation. The uveitis of JIA is particularly dangerous because it is invariably asymptomatic and must generally be detected by screening with slit lamp examination. Even during acute exacerbation with +4 aqueous cells, it is rare for patients to complain, although a few report an increase in vitreous floaters. Often uveitis may not be suspected until the parents recognize complications such as strabismus or an abnormal appearance of the eyeball due to bent keratopathy or cataract. So injection is usually absent even in the presence of severe uveitis. Inflammation is chronic non-granulomatous. Both eyes are affected in 70%. There is symmetrical severity of inflammation. Acute exacerbation, the entire endothelium shows dusting by many hundreds of cells, but hypopyon is absent. Posterior synecdoche are common in long-standing undetected cases. Bent keratopathy and cataract are common in severe cases. Other serious complications include glaucoma, which is common, amblyopia, maculopathy, cystoid macular edema, epiretinal membrane, cyclitic membrane, and phthisis. Prognosis: in about 10% the uveitis is mild with never more than +1 aqueous cells and persist for less than 12 months. About 15% of patients have one attack lasting less than 4 months. The severity of inflammation varying from +2 to +4 aqueous cells. In 50% of cases, the uveitis is moderate to severe and persists for more than 4 months, and in 25% the uveitis is very severe. Lasts for several years and responds poorly to conventional treatment. The presence of complications at initial examination appears to be an important risk factor. So the presence of complications at initial examination appears to be an important risk factor for the development of subsequent complications regardless of therapy. Good visual outcomes can be achieved by early case recognition and rapid referral to a specialist for immunomodulatory therapy. Investigation, systemic diagnosis and management should be performed by physician familiar with the management of JIA, typically a pediatric rheumatologist. Anti-nuclear antibody positivity denotes an increased risk of uveitis. HLA-B27 testing is useful in differential diagnosis, and a present may indicate an increased risk of uveitis. Rheumatoid factor is also useful in differential diagnosis. Screening. There has been a shift in recommendation towards long-term 3 to 4 monthly review intervals in all higher risk categories. Review should continue in most cases until the age of 12 years. Initial examination within 6 weeks of first diagnosis of JIA. Delayed early examination is an important cause of morbidity. Visual symptoms or suspicion of ocular signs like synecdoche, cataract, bent keratopathy should lead to urgent ophthalmological referral and slit lamp examination within a week. Initial 2-monthly examination for 6 months may be considered for all newly diagnosed oligoarticular, psoriatic, polyarticular, and enthesitis-related patients, regardless of the ANA status, following by 3 to 4 monthly intervals. In polyarticular, every 3 to 4 months, but some guidelines reduce the interval to 6 months. After a number of years, higher risk factors that might be considered in deciding whether to alter the interval include the presence of ANA, onset before 7 years of age, and female gender. So these 3 are high risk factors. So systemic onset and polyarticular rheumatoid factor positive patients, most authorities recommend at least an initial screening examination with some guidelines suggesting annual review. Missed appointment must be effectively detected and patients rebooked. Information for parents should include emphasis on importance of compliance with screening as well as the need to seek urgent advice should there be any cause for concern such as visual symptoms, ocular redness or clouding, Abnormal pupils, self-monitoring at eventual discharge from screening. Patients should be warned to self-monitor by checking the monocular vision at least once a week because the risk of uveitis has not entirely disappeared by this age. They should also attend an optometrist annually for an eye examination. Selected patients, such as those with learning difficulties, may require ongoing ophthalmological screening. What are the treatment? Before treatment, what are the differential diagnoses? Particular consideration in children include idiopathic juvenile chronic iridocyclitis, occurs in otherwise healthy patients with juvenile chronic anterior uveitis. Other types of juvenile arthritis and uveitis include juvenile reactive arthritis, juvenile inflammatory bowel disease-associated arthritis. Juvenile sarcoidosis is rare. Pulmonary involvement is less common than in adults in juvenile sarcoidosis. It may be granulomatous and involve the posterior segment. In the DD is Lyme disease, usually present with intermediate uveitis in conjunction with significant anterior uveitis. In the DDD is intermediate uveitis in 20% of all cases of pediatric uveitis or intermediate uveitis. In the DD is neonatal onset multisystem inflammatory disease. It's a rare idiopathic chronic relapsing disease that predominantly involves the skin, joint, central nervous system. 50% of children develop recurrent anterior uveitis. The absence of PSA and no tendency to glaucoma and cataract formation are characteristics. In the DD is Mosquerat syndrome, such as anterior segment involvement by retinoblastoma. In the DD is familial juvenile systemic granulomatosis, BLA syndrome. It is a rare autosomal dominant disorder characterized by childhood onset granulomatous disease of skin, eyes, which consist of panuveitis and multifocal choroiditis in giants. The aim of treatment now. The aim of treatment should be suppression of all active inflammation. These children should be referred as soon as possible to a uveitis specialist. Topical steroids are initially effective in 80% of cases. Mydriatic agents can be used to prevent synechiae formation. A relatively short-acting preparation such as cyclopentolate should be prescribed, discontinued as early as possible, particularly in monocular treatment of younger children susceptible to a development of amblyopia. Periocular steroids, oral steroids, NSAIDs, systemic immunosuppressive agents like methotrexate, infliximab, adalimumab. So these should be considered at an early stage as this has improved the overall visual prognosis in recent years. These children are usually under the management of uveitis specialists, typically working in collaboration with a pediatric rheumatologist. Etanercept should be avoided as it results in severe worsening of inflammation. Secondary glaucoma, a topical medication does not control the IOP. Surgery may be needed. The long-term result of trabeculectomy with mitomycin C in children with JIA are improved, but if they are using systemic anti-TNF medication. Biovelt implantation also results in good long-term IOP control, but is associated with 5% risk of hypotony maculopathy. The last is cataract extraction is often needed. Primary IOL implantation was a controversial issue in the past, but a low complication rate with good visual result has been recently reported with this approach in children on immunomodulatory treatment. Posterior capsular thickening requiring treatment occurs in approximately half.